I am not going to use slides because I find them very distracting. So just talk at me if you want to jump in. I'll stop. I won't talk for that long. I'll ask to leave time for questions. But if I say anything in the middle, then just wave at me and I'll try and spot you. So, as Eleanor said, I am Jess. I am a quite weird hybrid of a person. So I work for NHSX, which is the technology arm of the NHS. So we are all of the people who work on policy, regulation, designing stuff to do with digital data and technology from the Department of Health and Social Care, that's the government bit, and the NHS England, which is the bit that gives the money to the NHS. So all of the work we have been doing around things like the NHS app, things like NHS login, which is the identity token for everyone in the NHS, and all of the stuff we have been doing about AI has existed probably for about 2.5 years, but we just decided to bring everyone who was working on all of those programs together into one big team, as opposed to what we were doing before, which was kind of you over here make a decision, you over here make a separate decision, you over there make another decision, and you over here make another decision, and then we'll have a bit of a debate. Everyone now hopefully makes a decision in the same room. I say hopefully, we have only existed since April, so the proof will probably come in 6 months' time, whether or not that actually works. So that is part of what I do. And there I am the SME, or the subject matter expert on AI, and then I also work at the Evidence-Based Medicine Data Lab in the University of Oxford, and I am a member of the Oxford Internet Institute's Digital Ethics Lab. So I kind of, like I said, this weird hybrid person where I bounce a lot and do a lot of different things, and I live in Oxford rather than in London. So, kind of going to talk a little bit about what it is that we have been doing in AI in health, what might be some of the possibilities, but also what might be some of the harms, some of which you've already heard about a little bit, and also what we can try and do to try and mitigate some of those things. But first of all, because you've just been hearing all about data, and I kind of want to check that you're listening and awake and not bored to death, because I might be really boring, I'm going to ask a question. Who thinks that if it's your medical record, so this is the record that is generated by your GP about every single time that you go to the GP, they make a data point, who thinks that that belongs to you? You own that data. One person? 2 people? 3 people? Okay. Who thinks that the NHS owns it? And then the reverse, so who thinks you should own it if you don't own it already? Everyone? And who thinks it should belong to the NHS and it's a national resource? So these are really big, what I would call, from the Digital Ethics Lab perspective, open questions or philosophical questions, because there isn't a technical answer one way or the other in the law. At the moment, it's quite a hotly debated topic, and some of the things that the previous talk was touching on around how do we commercialize that, and how do you enable the use of that data by companies like Google or by Babylon, which is the other one that gets everyone a little bit upset, to enable it to be used for good without it causing lots of harm, either from the perspective of what's done with it, but also from the perspective that this is something that the NHS could profit from, but might not. Equally, people are quite uncomfortable with the idea of us making money off a very, very personal set of data. We have this kind of quite strange split where we test with people a lot, that people are generally very happy, I say generally, with the idea of that data being used for medical research. So if you are Cancer Research UK, for example, they have really big data sets that belong to people, all people who've got breast cancer, for example. They will have access to those data sets that actually sit with Public Health England. And generally, everyone is kind of like, yeah, that's fine. If you use it to solve cancer, I'm cool with that. And we have a program that's called the National Data Opt-out, which allows people to select whether or not that happens. Then people get a little bit more uncomfortable if we start saying, Well, actually, I want to start using some of that data to plan or to do what's called commissioning. So I want to know in Richmond Borough, there is a higher population of people who have diabetes than there is in, say, Tower Hamlets. So I'm going to spend more money on diabetes in Richmond than I am in Tower Hamlets. Some people start getting a little bit more nervous about their idea of their data being used for that purpose. And then people get even more uncomfortable with the idea of Google coming along and making a commercially profitable product which they can then sell overseas. These are the kind of questions that we are trying to deal with before we have even got into the point at which we are talking about the actual AI and its development. And we have to think about the interoperability of the data, we have to think about the ownership of it, we have to think about what standard is it in, we have to think about where does it get generated. And the big thing, which again we've kind of previously touched on, is that what we have now is a lot of this data is health data, but it's not medical data. So the NHS owns medical data, or we have access to the medical data, so anytime you go to a hospital or you go to a GP or anything like this, but load more rich, more interesting data is generated by your mobile phone, or by your life in general, what we call your social determinants of health. So for example, dementia, there is a better ability to predict the onset of dementia from looking at people's shopping records, so things like their Nectar card points, than there is from your medical record. Because you can start looking at people's deterioration in patterns. So, Joe Bloggs has all his life shopped on a Thursday afternoon and bought X, Y, Z. And then all of a sudden, he started going randomly on a Wednesday and buying 1 box of cereal. And then sometime on a Friday and buying 3 bottles of milk. And that starts to be able to be a much better predictor of someone going into mental health decline than your medical record. Similarly, some of the stuff that we do in the Digital Ethics Lab is looking at the ethics around digital psychiatry. So this is the idea that we can predict people's mental health outside of the healthcare system better than the healthcare system can. But these industries where this is happening, the big one is in financial services. People suddenly go on a massive splurge with their money and they're spending all over the place. That's quite often an indicator that somebody might be having what's called a manic episode, where they've gone into a sort of dangerous mental health space. That financial services provider might have what we call a duty of care to interfere with that person and say, hang on, actually we think this is a medical problem, we should stop. But they don't have any of the regulation or the governance or the protection that we would have in the healthcare space with how do you do that in the right way. Another really super interesting problem that we have faced a lot in this space is social media and suicide. So lots and lots of people talk on social media, whether that be Twitter or Instagram or Snapchat or Facebook or anything, and they are quite often talking about how they feel. And sometimes some of this is what we call suicidal ideation. So this is people start promoting the idea that suicide is good. And so there are some people who say that we have as the central NHS a duty to produce a predictive algorithm that can automatically take this content off social media, which is what we do now for terrorist content. There are things that auto-flag and then it will take it down. So there are some people who argue we should do the same thing for mental health harms like suicidal content. And Facebook does do this in the US. It will flag if it thinks that somebody is suicidal or is promoting suicide. The problem is we have an issue with semantics. So some people also use social media to talk about recovery or to reach out to people and to start getting help. There are lots of people, for example, who post they have like a tattoo of a semicolon, and that means that they may have tried to commit suicide and they've survived. So it's like a pause, but I continue living. And we don't have the ability yet with an algorithm to tell the difference between somebody who is talking about suicide in a positive, I want to get help and I want to talk to people way, versus people who are doing it in a harmful way. So these are the kind of ethical considerations that we have to start thinking about. And then we have to start thinking about how they might happen at different, what we would call a different level of abstraction, but what I really mean is the different perspectives or the different scales at which this stuff could start harming. So we know that AI can do huge things for healthcare. It can improve diagnostics, it can produce predictive ability, so when is somebody going to get sick? It can, or I'm less of a believer in the idea that it can do personalised health and tell you, well, you, instead of your optimum heart rate being this, it should be the optimum heart rate for you is this, based on your specific personal data. And the other one, the bit that's really boring, that no one else cares about, but I really love, is what we call operational efficiency. So this is the back end of the NHS. So like, when are there going to be appointments available? Who's got access to them? When do we need to provide more nurses in which hospital, in which place? All of this stuff, fantastic. Mostly fictional at the moment. You will see quite a lot in the press, a lot of hype around AI in healthcare, and people saying, oh, we can do all of this, it's amazing, we're going to solve the world. Honestly, if you listen to some people in AI and healthcare, they will tell you that no one is ever going to die. Like, we've solved it, people, it's fine, everyone is going to live forever because we have AI. Actually, the reality is, in most of these instances, they're what we call proof of concept, or it's a research project. So they have done it in a really highly constrained environment, and they've shown that it works. And then I say, great, but can you please now go and do this in an actual population setting? And they're like, no. One of the big problems with that is the data sets themselves. So previous speaker talked about IBM Watson. So Watson's main product is IBM Oncology, so for helping the diagnosis of cancer. And the place it's being used the most often is in China. China has a really big problem with its healthcare system. It has a massive population. Most people live in really rural areas and they don't have very good access to healthcare. So they have been really early adopters of IBM Watson. Problem is, IBM Watson, trained to recognize lung cancer in America, then used in China. Who thinks the people in America are the same as the people in China? They're not. So we already have a massive accuracy problem, or a really big bias problem. Similarly, we have over here in the UK, we have one of the products that we were looking at, can recognise breast cancer. Fantastic. It's even been through what we call the CE marking process, which is when it's gone and it has been officially classified as a medical device, the same as like an X-ray or an MRI. Trained on a Hungarian population. We tried to make it work in Britain. Turns out Hungarian boobs, British boobs, not the same. So we're suddenly like, oh, we have to try and deal with this. So all of these questions start making it harder and harder and harder to make AI for the NHS work at scale. Especially because all of the problems I have just mentioned are only talking about the individual level. So does my Fitbit work for me? Yes or no? Does this scan recognize my cancer? Yes or no? That's an individual level problem, and it might have an impact on the accuracy of your diagnosis. It might have an impact on what's called your autonomy, so your ability to make a decision or an informed decision. And it might have an impact on your, what I call, your integrity of self, so your ability to understand who you are as a person because it's happening in a data space. As a system, so I remember the NHS is responsible for everyone in the whole of the country's healthcare. I also have to care about impacts that might happen at the group level. So have we created systems now where we are better at providing for group A than we are at providing group B, and we are creating huge inequalities? Really big example of that is what we call e-health literacy. So your previous speaker was in the way that we are talking about, and then they do not have the health literacy to understand. Big example here is anti-vaccination on Twitter. So I don't know if anyone saw yesterday, but there was a big news story that Britain has lost its measles-free status. This is a huge deal. 3 years ago, we were said, World Health Organization, there's no more measles in the UK. Measles has come back to the UK because a lot of people are not vaccinating their children. Now, there are probably multiple reasons why this is happening. I'm not going to oversimplify, But one of the main reasons that I've done some research on, we have done in the Oxford Internet Institute, is because people trust social media health information more than they trust information from a boring health website, because it has what's called social, it's got like a social signal that is trustworthy. It's got likes. So people who have a very low level of e-health literacy, they have no ability or a much reduced ability to tell whether information is credible or trustworthy. So what they do is, it's called a heuristic, it's a mind jump to see what's the simplest way that I can determine whether or not this is trustworthy. Other people think it's right, therefore it is right. It's the same as your mum saying to you, oh well, if everyone did it, would you do it? Well, actually, psychologically, yes. Sorry, mums. So this is kind of the problem that we're having to try and deal with, is that we've got these groups of people that we are now maybe providing worse healthcare, or we could provide worse healthcare in the future, because we want to shift everything into the digital space, because it generates more data, which allows us to do more AI. The next thing, the next level up, is what we might call interaction. So what's the relationship between a human person as a patient and the clinician? That's actually quite a well-respected type of relationship. And we know that healthcare is not just about numbers. It isn't just something that we can automate, particularly in the mental health space. I don't necessarily, there are some people who really want to talk with a chatbot. That's actually much better for them in a mental health space than it is to talk with a human, because there are things like stigma with mental health. So a really big one is soldiers who have post-traumatic stress disorder have a real, like, I'm a soldier. I do not go and talk to a person about my feelings, but they will talk to a computer, because there is a perception that the computer is more neutral and it will not judge them. There are other people who do not want to talk to a computer, who need that human level. And so this is one of the things that we try and answer questions about, is the difference between could and should. And some of these things I think are really obvious. Like, there was a story in the US a while ago where a hospital in America wheeled a robot and an iPad on, and the doctor via Skype, via the robot, told the patient in the bed that they were going to die. Now, to me, I feel like that is an obvious could versus should. I don't think we should be telling people on a screen that they're about to die. But apparently, to those people in the US hospital, not obvious. There are more subtle versions of that could versus should. So should a computer give you a diagnosis? Should it tell you that you have a risk of heart disease? Should it do this? And so the other big thing that we start talking about at that group level and the system level of the impacts is the difference between automation of role and automation of task. So a lot of the time you will see in the press, and I want you to get super skeptical about this, is, oh, robo-doctors coming. We're going to get rid of all the GPs. None of them will exist. We'll replace them all with a computer. No. We might be able to automate parts of the pathway for different things, but we're never going to get rid of the whole thing, because that would be an inhumane way of utilising the technology. But we also have to think about, for example, image recognition. So image recognition is the biggest thing in healthcare at the moment. So recognising breast cancer, recognising lung cancer, recognising any of these things. There are two big problems with this. One, if we deploy it in the NHS, we've really sped up the first part of the system, and we have done nothing to increase the capacity of the system to cope with you. So it's like going, oh, well, currently we have enough doctors to treat 10 people, and we recognise about 10 cases of breast cancer a day. All of a sudden, we're going to recognise 250 cases of breast cancer a day, and we have still got the same number of doctors. You then have all of those people living with a potentially worrying thought in their head and no ability to increase our ability to cope with it. That's number one. The second problem is a lot of this stuff is being deployed at the patient level or the user interface level. So, I don't know, anyone can go on the App Store and you can look at this thing called Skinlytics. It will let you take a photo of a mole on your arm or anywhere, or a bump on your skin, and it will give you the risk rating of whether or not that might be cancerous. Problem is that that company does not want to get that wrong. So it entire incentive is skewed towards giving a false positive. So it will most likely tell you you have cancer than not, because the risk to the company of giving you a misdiagnosis and saying you don't have cancer, you're fine, is much higher than giving the person a potentially terrifying, you have a high risk of skin cancer notification, because people like me have thus far failed to answer the question of liability. So if an AI gets your diagnosis wrong, who goes to jail? No one. At the moment we have tried to answer this question. I have gone to every single lawyer ever, and all of them tell me, because the way that the law system works in this country is on precedent, until it happens, we don't know the answer to the question. So, all of this means we have quite a big problem. We have a responsibility as the NHS to harness every single type of technology that we think could save people's lives. We have a healthcare system whose IT is nowhere near ready for the deployment of this system. Nowhere near ready. Like, when we're talking about Windows before most of you guys were born, that's where the NHS's IT is. So we have to improve that. Then we have to answer all of these really technical questions. Then we have to work out where in the pathway do we put it. And then we have to deal with the fact that the law is what I call the MVEP, so the minimum viable ethical product. It's the absolute floor of what can you do. It does nothing to talk about what should you do, or even what people want you to do. So there's a very big difference between social acceptability and social preferability. So there's some things we have done. We have what's called a code of conduct for data-driven health and care tech. It went live in February. It's a big policy. It has like 10 different behaviours of what we expect people to do. And now what we have been doing is working with lots of big companies, whether it be Google, whether it be IBM, some people from IQVIA, to test whether they are actually using that and how. Because this is the big thing with AI ethics. Is everyone in the world, like 84 different sets of AI ethical principles now exist. We'll tell you, these are the principles. Be beneficent, be non-maleficent, be fair, be accountable, be transparent. But no one has answered the question, how? So it's all very well and good to have a long list of principles and be like, yes, this is fab. I'm going to put this as a big sticker in my window and do what we call ethics washing, or ethics signalling. I've done it, yeah, great. But no one is proving whether or not they've done that. So this is what we're trying to do, because if you take healthcare, super sensible, super sensitive, let's take just the one example of explainability, which you'll hear about a lot. People want to be able to understand how a model made a decision. Right, in healthcare, think how important that is. I've gone to my doctor. Doctor, my leg hurts, this hurts, I feel quite sick. Doctor goes, I need to amputate your leg. I'm like, why? I don't know, computer said so. So we need to work all of these things through. So we turned the code of conduct into what's called the self-assessment framework, and it has a whole load of prompts. So it says, this is your ethical principle. So principle 7, for example, is tell us what type of algorithm you're building, the ethical assessment of its data use, and how it will impact the system when it is implemented. And then we have come up with an entire guide as to how you actually meet that principle. And we've tested it with about 15 companies. The idea being that we will produce standards and principles and guidance that build on those very high level concepts and actually start enabling us as the system to monitor whether or not people are doing it. So that's kind of where we are. This is why a couple of weeks ago you may have seen or may not have seen, because it's not that interesting, but we announced the launch of the NHS AI Lab. We got £250 million from the Treasury to spend a vast majority on this, on the regulation of AI for healthcare. So how do we make sure it's safe? How do we make sure it's ethical? How do we make sure that it's not harming people? And how do we harness its ability? And I make that last point because lots of people who are anti the concept of AI in healthcare, or super nervous about all of the ethical issues, which I am one of them, but they forget that actually the potentially biggest ethical problem is opportunity cost. We know we can use these technologies and harness them properly to save people's lives. We have a duty of care as the NHS, which its principle is do no harm and we are for everyone and free at the point of care. We have a primary, prima facie duty to capitalise on that opportunity, but we have to do it in the right way. And so that's the challenge that we face, and that's